Hello, I'm Dr. Steve Karstensen, Chief Dental Editor of Dental Sleep Practice, a Medmark publication. Welcome to an educational discussion and Q&A with Dr. Justus Hauschild. In our webinar today, we'll be discussing co-sleeping as a risk for sleep bruxism and morning headache. Associated with this presentation is a free CE quiz. At the end of the webinar, we will email all registrants the presentation replay along with instructions on how to access the CE quiz. Before we get started, I would like to invite everyone to use the Q&A feature in the control panel to ask any questions. They'll be answered at the end of the presentation as time permits. Now, I'm pleased to introduce our speaker. Dr. Justus Hauschild is a clinical practicing dentist and a specialist for both craniomandibular function and dental sleep medicine. He has founded the first dental practice in Germany focusing exclusively on craniomandibular function and sleeping disorders. Dr. Hauschild is a former member of the board for the German Society of Dental Sleep Medicine and current member of the board for the German Society of Craniomandibular Function. He also serves as a reserve officer in the German Bundeswehr, trained in civil military cooperation. Thank you so much for joining us, Dr. Hauschild. Now I'll turn it over to you to learn more about today's topic.
Okay, thank you very much, Steve Carstensen, for invitation to DSP. I'm really honored to be here tonight. And also thank you very much to Michelle Britius and Robin Voigtke, who helped me very much to set this up. It was not used as my first webinar actually in the United States. So I'm really excited about it. And I hope you have a good half an hour, quarter of an hour of information from me. And also want to say a warm thank to Ms. McGarthy from Pantera Dental in Quebec, Canada, who set up this webinar for me and to put all the connections to DSP and also to Michael Lutsch from Germany. This is actually a very nice link that we throw over the ocean, and I'm very curious about your questions and about what we can share together to make dental sleep medicine just a bit more common and just bigger. So, and here are my slides, and we start with a title. I've published this in the Journal of Craniomandibular Function recently, and I even won a prize for this presentation a couple of years ago because it seemed obviously to be a good idea to talk about co-sleeping. And this is just a little hint. We also have such restrictions for young people. Actually, this is nothing, we're not talking about any issues that are not for the screen anyway. So this is me in my practice. You've seen my live pictures a couple of minutes ago. And I've indeed founded the first practice focusing exclusively on dental sleep medicine and craniomandibular function. I've been a dentist for 25, 26 years in my own practice, just doing general dentistry, having a lot of fun of it. And I can really state this is dental sleep medicine and function comes in the middle from general dentistry and goes back there. So everything what we discuss here tonight is good for your dental and general practice as well. I have no conflicts of interest. I have my dental practices in two places here in Hanover in northern Germany. I've written a book a couple of years ago, and another one is in project, which is a textbook about dental sleep medicine by Quintessence. I get fees for lectures, of course, and this one is sponsored by Pantera. Thank you very much at this place here. And I have no participations in any enterprises or products. So I'm quite independent. And let me pick you up at a place which is used to your practice. You welcome a patient at your reception, and this woman has been sent to you or has come to you because she has heard that you're pretty good in craniomandibular function, because she tells you in the first appointment that she has all symptoms and signs of temporomandibular dysfunction, and she has headache, she's grinding with her teeth, and you might as well take a look at it and help her. You probably know this from your own practice. So what you do is, following a workflow, several protocols that we have, you do an examination of the patient, you fill in some forms like DCTMD or whatsoever, just to write down everything what you want to know about the patient and to have a comparison whether your therapy would work or not. And what we usually do is then give the patient splint, for instance, a Michigan splint. You give them manual or physical therapy, osteopathy, something like this, and I prefer really to give them exercises to help to get their myofascial pain away. So this usually works, and you have a patient who is satisfied, who says, "Okay, you're a good doctor. You helped me, and you're quite happy with it too." If there wasn't time, so time goes by. And after a while, you have a recall, and the person comes again. And she says, everything was fine, but it didn't help really on the long way. So I'm still having my headache. I still have my TMD. And could there be anything else? Could it be stress? What could it be? And so you ask her, when do you have this pain? And she says, I wake up with it. And then your next question could be, well, if you go to bed, do you have headaches? And she said, no, I go to bed without any pain. But you wake up with pain. So something has to happen in the night. And the first question you should ask is, excuse me, do you share your bed with someone else? And she said, yeah, of course, with my husband sleeping there. Oh, is your husband possibly snoring? And then she says, yeah, he's heavily snoring, and this is really going on my nerves for the last 20 years we've been married for. So there you have a point where you can say, okay, this is certainly stressful. This stresses you, and if you're not have had a restful sleep, you're stressed on the next day too. So we all know stress is linked very much to temporomandibular disorders, and of course to Bruxism. Bruxism is a condition which is very helpful to get rid of stress, to get rid of cortisol. And so we have those two forms, the awake bruxism, and we have lots of evidence that this is a good coping strategy to get rid of cortisol and other hormones that stress you. So bruxism is sometimes necessary, and it's not even anything that we consider to be pathologic. You need it once in a while. And there's not only awake bruxism, but there's also bruxism you do during the night, which is called sleep bruxism. And there's also a lot of evidence about it, why sleep bruxism is a very good strategy. There's a group in North America, in Montreal, which has done a lot of research about this grinding in the night. And I'm talking about very experienced dental sleep physician. This is Gilles Levigne from Montreal, and he's done research about the genesis of sleep bruxism. And let me show you just this little cascade, which is very interesting, because you can see that it all starts. I will see whether I have my pointer here. I'm sorry, this is not helpful, but here we have a pointer, laser pointer. And you can see it all starts with an autonomic cardiac activation. That means a rise in sympathetic cardiac activity. And this is followed by a change in your brain activity, which can be measured, of course, in the night as well, which leads to a rise in heartbeat and also in the rise in muscle tone, in order to end in a rhythmic masticatory muscle activity, RMMA. And this is tooth grinding. So we have here shown that we have a chain reaction between something that really is stressing you, because this is not the nervous system which is active in the night. You have the parasympathetic part of the autonomic system working, and the sympathetic is sort of asleep. So if this gets activated, we'll have a tooth grinding and so also a micro arousal. You wake up. So you have a disturbed sleep. And this is very interesting, because this is what happens between couples. And in this bed where we met our patient, we have different diagnoses lying there. We have someone who is snoring, or possibly having a sleep apnea. We don't know yet. We have to find it out. And possibly someone who is doing sleep bruxism, because this is very well associated with sleep apnea. On the other side of the bed, we have someone who can't sleep, who has an insomnia, or who rather is an insomniac TMD patient, because she has problems there. That's why she went to her practice. She also could have an obstructive sleep apnea. We don't know yet. We have not found out yet. And of course, we can see, and we saw all symptoms of sleep bruxism here. So we have a lot of diagnostics in this bed. And what we can sum up is that there's no restful sleep in this bed for both of them. And as we know that sleep quality is linked or is associated with pain and vice versa, we can say that we can state that there seems to be an association between painful TMD and the sleep quality. This is shown by a huge systematic review by Drevik some 5 years ago. So you can see on the bottom line. And this is something which I found interesting to find out. So where can we get into this, literally into this bed and find out what's really going on with the patients? Let's take a closer look at sleep, what sleep is. And you all know this, the sleep stages, and that we sleep in cycles, and what those stages have functions. We see this on this slide, and the sleep architecture we have. The light sleep stages here in yellow, and non-REM 1 and 2. It's about 50% of our night normally, and we have those deep sleep stages, and 3, which is a bit more in the first half of the night, and of course the REM stages, where we have this paradox sleep with a high cerebral activity. All those stages have, as you know, functions, and one of the most important function of the deep sleep stage N3 is, of course, strength of your immunological system, wound healing, you setting up growth hormones, and of course, the activation of the glymphatic system in your brain, which helps to get rid of toxic proteins that can also cause Alzheimer. So this is a very important thing. This is a vital function. This is not, this is set up by nature, by evolution, and part of your circadian rhythm. So this is something that really takes place. And this is, of course, now getting disturbed. As you can see here on the right side, we have a normal sleep hypnogram, and we see a disturbed sleep hypnogram, and on the left side, those micro arousals, which are those little arrows that we can see here on the bottom hypnogram, which is a sleep that is disturbed, which is fragmented. And those fragmentations can, of course, be snoring sounds, could also be apnea, apneas that are taking place for a person. Anything that disturbs your sleep gets you out of those important N3 sleep stages and make your sleep definitely non-restful, no matter how long you lie in bed or not. So this is the idea behind it. And if you now take another look or look at another a study from the group in Montreal, from Cara. As you can see, Lavinia has been in there as well. You can see that those RMMA episodes sort of lead into a sleep state shift. We have a sleep state shift whenever those RMMA occur, and normally into a lighter sleep stage. So that's actually what we see when we have those microarousals and when we awake. And this is the same we've just seen on the other slide, but it's just a bit more sophisticated. You see the genesis of an RMMA episode. And you see here all those channels and all those points we measure in the classical polysomnography, the PSG, which is been invented by Rechtschaffen and Chaos, so some 60 years ago. And this is something which is, of course, quite basic and the gold standard. But it is, in most cases, an individual affair. You have only one person being measured and being monitored in your sleep lab. But sleep isn't an individual affair. You have normally someone next to you lying, even if he's not here, and even if you get disturbed. So we should take a look why sleep is something that we have not alone by ourselves. And there's a long history of co-sleep, and 1,000 years ago in evolution, it has been very sensitive to sleep in groups, because if we are asleep, we have no protection against danger. And if one of the group would be awake and stay awake and warn the others, you can have your restful sleep. And that's about the strategy that has been through mankind over all those centuries and thousands of years. So as we can see here in this painting of a cave in Asia. But we see it on paints pictures like this one here from Lucas Cranach, about 500 years old. You probably know this scene from Jesus praying in the Garden of Gethsemane. And here's a danger, actually, and his fellows are sleeping in a group. Actually, there's no one awake apart from Jesus, but he's concentrating on his prayer and he's not watching the danger. So another cultural proof of the benefits, or the benefits of co-sleep. Co-sleeping has been researched very well and in a very sensational way by this person, Wendy Truxell from the United States. She's one of the leading sleep scientists, and it's really interesting what she has found out, and she has a lot of good articles I can really recommend. You can also watch her on YouTube. There are some nice lectures she has given, and it's really interesting what she has found out. I will have some slides that refer to her research. And she has written that throughout history, humans have derived physical and emotional safety and security, particularly during times of real or imagined threat. And that led me to this picture. You probably know this is from Asterix, quite popular here in Europe. And this is a situation where they're all afraid and frightened. And so they seek each other's connections as far as they have one. So this is quite plastical to describe why danger and why stress brings you together. Actually, talking about cartoons, the inventor of cartoons comes from Germany. This is Wilhelm Busch. Wilhelm Busch has lived some 200 years ago, and he's done those little paintings, those little cartoons, and having with little verses under it. And I had it in German, but I tried to translate it into English, which might be quite ridiculous, but I know that Wilhelm Busch was a man of humor, so he would probably have no problem with it. So this one says, "In der Kammer, still und dunkel, schläft die Tante bei dem Onkel." And I've translated into "In the chamber, nice and cozy, rests the Fritz with his wife Josie." So you can see they're sleeping together and sharing a bed with each other. In the next scene, it says, Und mit Murren und Gebrumm kehrt man beiderseits sich um. I've translated it, and with a snoring, buzzing sound, both are turning then around. So you can see 200 years ago, not only co-sleep was a cultural and social established behavior, but also the non-restful or disturbed sleep. So this is something which is quite well known. What do we know about co-sleep if we take a look at the current literature we have? And the first thing is that we don't have much literature about it. There's not very much evidence. The most evidence is about social or psychological aspects, such as sleep and connection with relationship. Wendy Troxel has done a lot about it. We can say that, of course, chronobiologic differences between bed partners can cause problems with sleep and co-sleep. And we also know, we learn from research that it is mostly that individual persons get examined and diagnostics and are into research and studies. So it seems to be quite exotic and to talk about co-sleep and sleep partners. Of course, because studies are very, very hard to set up. You have no sleep labs with double beds, and you have to really have lots of pairs, lots of couples who could participate in those studies, but it's not very easy to sort of set up those studies. There are, at my knowledge, only 3 studies. One is from 1969. Monroe has done it, and there's another one in the mid-70s or 80s. And I show you one which has been set up in Germany in the year of 2017 with all this interesting results. What we know is that co-sleep, of course, causes interaction. It's not that we are switched out in the night. We communicate with each other. We communicate not by words or listening. We communicate with the temperature of the other body. We communicate with the smell of the other body, with hormones that we might as well smell or not, or movement, and of course some sounds. So we have interaction, and this interaction makes us sleep better because we feel that there's someone else in the bed who might give us protection. And so the last night's sleep quality is something that, of course, gives a direction for the next day. So how do you interact with your bed partner the next day? As this is shown in this bidirectional association study, which you can see. So if you had a bad night, your day might be not quite good as well, and so on. So we have a hint here that co-sleep, or disturbed co-sleep rather, might be harmful for your relationship. Of course, we were talking about the advantages of bed sharing, and of course there are some. We have an interaction that gives us protection, that gives us safety, that gives us love, and just to feel well and to be in a very safe situation, which we have to sleep, because we are unprotected if we sleep indeed. But we also can have the disadvantages, and lots of couples are thinking about separate bedrooms. Actually, this is something that Wendy Troxel has called sleep divorce, that couples try to separate each other during the night, which might not be good for the relation, but we know that there's no one size fits all. So it could also, for some couples, be a good thing to rather sleep in separate bedrooms. Anyway, we should summarize what we have in literature about this, and we can say that it is more impairing for women than for men. So if there's someone suffering from co-sleep, then it's more the women, because they have a lighter sleep than men have. But we also know they're more receptive. They want to have co-sleep, even if it's impairing, even if it's stressing for them. This is something which Wendy Troxler has found out. And we know that co-sleep impairs the sleep quality objectively. So what we can measure, what we can monitor is that it's worse if people sleep together. But the subjective quality for the persons who sleep as a couple or share a bed is definitely better. This is something, and here you can see the study from Munro from 1969. So it doesn't make really sense to leave the bedroom for one night. Of course, some people do, and are on flight on the sofa in the living room just to spend the night there because it's not that noisy and not that stressful as it is in the bedroom. But it doesn't really help to change your sleep architecture and your sleep quality. And a huge study from Alfberg 25 years ago says, and this is very important, that we know that bed partners of snorers more frequently suffer from sleep-related problems such as insomnia and awaking with headache. So here we have a quite old study and quite old link and hint, of course, that we should ask people with morning headaches for a bed partner or about a bed partner who snores. And so we know that if someone is not only snoring but having sleep apnea, this is setting up a very high level of stress for both bed partners. Of course, for the one who suffers, as you know, within an obstructive sleep apnea, we have a raise of stress level, and this, of course, raises the stress level for the co-sleeper as well. The problem is that no one scores and measures the co-sleeper. We know that if an apnea patient is treated with a CPAP mask, then this makes the quality better for the sleep partner as well. So it's a benefit for both bed partners. And we know this if this relationship has conflicts, if this couple is having problems on another way, this could impair sleep quality, as we have seen on this slide a couple of minutes ago. Dreves et al., and I'll show you this study in a minute, which is the third study of co-sleepers in a sleep laboratory, has shown that we have a synchronization of sleep architecture. And this is very interesting, very helpful to understand if we take a look at the measurements in a couple of minutes, what I've done with bed partners. So we have a synchronization between bed partners for the good and also for the bad. And this is the study, 2017 in the city of Kiel, which is quite in the north at the Baltic Sea. Are we in sync with each other? And here we had four healthy heterosexual couples, young couples, 20 to 29 years old. They had no sleep disorders or problems in the relationships. And they were studied 2 nights in a sleep laboratory and had to fill in protocols for every night. And they found out that we have a subjective benefit of the sleep, and they felt recovered and refreshed by those nights together. It was also objectively stated that the sleep duration was prolonged and better, and that they had even more N3 and REM stages. We could also find out, or they could find out in the study, that they had a stronger synchronization of sleep architecture, which I've just mentioned, and a shorter N2 and 3 latency. So it was very efficient sleep they had. Indeed, what you all know, talking about REM sleep, which is the sleep where you have those cognitive benefits where your brain is highly active, and of course social parameters and the quality of a relationship has an impact on this REM sleep, which has been shown in this study. And so therefore you could think that it's this relation between sleep quality and health, which you all know, has to be modified and said that we have sleep, health, and relationship. And those three items really work with each other. So you have to take a look at not only of sleep parameters, which you can read in a sleep lab, but you also have to ask people about relationship. This study had a poor number of participants. I told you it's really elaborate to set up such studies, but I hope they're working it. But I've met someone of Ms. Weinhardt from the study recently, and she said, Mr. Dreves has disappeared from Kiel. He's now working in Norway somewhere, and he's far away from any sleep labs. So it needs more research done in this region. Let's get back to our couple. So if you want to help your patient has been in your practice, you have to see their spouse, their husband, their bed partner, whatsoever. And let me tell you, this is really hard for us men. We don't want to go to the doctor with our wife, and it feels like a little boy or someone who's been accused because he's disturbing the night, he's snoring, and he's the one who's really accused. And we dentists are not trained for partner counseling and couple treatment. So we really have to be very, very sensible at this point and very careful just to get the right sound to talk to the husband. This is really the hardest part in my experience, the hardest part of it, to get this snorer, this husband, this bed partner into your practice and talk. And one of the best strategies is to take it easy, to do it with a sense of humor, and to, of course, tell about your own history. And I myself have been a snorer, and I've been going on the nerves of my wife, and she had a morning headache. So this is why I actually came to this strategy. We can help those men. We can say, okay, if you don't believe that you're disturbing your wife's night, if you don't want to have any therapy, and if you don't want to wear a device, it's all fine with me. But do me one favor, get yourself an app like this one, like SnoreLab, and record yourself. Record yourself and listen to you what the sound is like. And I've done this. This is one of my nights without a device in 2021. And I hope that you can just hear what now happens when you listen to your night. Okay, this is might be a bit impressive, but if you listen to this, you really want to get rid of it. You said, okay, this is not me. This is not what I want to sound like, not even if I sleep. So please help me, please let me get rid of it. So this is a good strategy to get the husband back into your practice and back him for anti-snoring device. And if you have them here in your practice, you have to convince them that it's very, very sensible to do a measurement, a common measurement, a synchronized measurement, because there are no sleep labs with double beds. And there's one device which I can really recommend. That's the watch pad. This is based on the peripheral arterial tonometry, which measures, of course, stress. And I'll show you how it works. This is this little video from YouTube. You have this device stuck on your finger, which is measuring the pad signal. This is the base and the heart of it. It's very easy to carry. You have it on your right or your left finger. It is linked to a smartwatch, and to another sensor which is located on your chest. It's very easy to wear. You can sleep quite well in your own bed. Movement detection, actigraphy is on your hand. You have a snoring microphone, which is also measuring your body position in the chest movement. And on your finger sensor, you have your heart rate, oxygen saturation, of course, the PUD signal. So an AE will help you to get all those information together and to have a quite useful and validated protocol, which you can use to distinguish whether there's someone having a sleep apnea or only snoring. And this is how it looks if you do the analytics here. You can see those signals and those channels, PAD signal. Here in this one, you have the PAD amplitude, where you can see this is a region or a time where it's a bit stressy, even when this PAD signal gets a bit lower, a bit narrower. You have the pulse rate, you have the oxygen saturation, the respirant movement, which is very important to distinguish sleep apneas and actigraph, the snore microphone, and the body position. And you can see then those sleep stages that we've been talking about early on. So this is really helpful just to measure it. And what's even better in it, you can have two of them because they're synchronized, and you give them to both bed partners and then compare what happens as a reaction on the other one. And that's really neat because they are in their environment. The surrounding is that what they know. It's not a sleep lab. It's not a hospital. It's their own bed. It's just a little device I'm wearing on the left hand. And they can really record a quite representative night. So, and what you do then, of course, a couple measurement is a couple treatment. You give the mandibular advancement device to the snorer and to the stressed person, a Michigan maxillary splint or whatsoever you want. And you can see it is not an individual affair. It's a couple sleep. It's what Wendy Troxel called a sleep alliance to make your night better, to make your sleep restful. And as you can see, I can prove you that we have done it as well. This is my wife here, Joanna, and me. And we are in our bed just preparing for night and having our splints ready to be worn. And of course, we have here quite nice nylon splints from Canada that we really love to wear. We have better nights with it. And of course, a really nice and functional relationship. So what are the consequences that we have from this dyadic nature of sleep and sleep disturbances? We should always think about someone else if we talk about sleep. We should not see one person only. We should ask for a bed partner and remind a bed partner and respect our bed partner, even therapy. We should also understand that we have bilateral effects. So if you have a snorer, then you could possibly not see him, but only see the other side of the bed where a patient is with sleep bruxism and morning headache and fractured denture and whatsoever you see in the oral cavity. So you have to widening our angle of view on sleep bruxism. It's not sleep bruxism is possibly not an individual condition. You have to see this under the dyadic aspects. There are no double beds in sleep laboratories. Perhaps we should change this. Could be really an improvement for diagnostics. And of course, we have to have more evidence, more research about this subject. And one thing which is quite easy is, of course, give information to the patients. They know that they are sleeping in a bed together. They know about the problems. And they sometimes wonder why there are not any possibilities in diagnostics for them as a couple to be diagnosed. So we should really be realistic here and pick up those patients' wishes to improve their sleep and work on a sleep alliance. And last but not least, we should, of course, talk with the insurances. The insurance of the snorer would never pay for the device for his bed partner because it's a different individual. And sometimes we should really invite the insurances to think about whether it's better to give him a snoring advice, because she would not have expensive costs for drugs, for devices, for physiotherapy, and so on. So at the end of this webinar, we can summarize that co-sleep is a social cultural established behavior. We have a traditional view only on the single person, and this should be changed. We have to respect the social context of sleep, and this could be really a shift of paradigm and treatment. We should also see that relationship is really, really important thing on the way to have a restful and successful sleep and a successful therapy. And we should also jump on that train, because if you look at the yellow press, you see that sleep is the new sex. People are talking about sleep, they want to improve, and we know how to do it. As a take-home message for your dental practice, I can really recommend to regard co-sleepers in your anamnestic, diagnostic, and therapeutic strategies. You will improve your dentistry. And if you know and talk about stress with your patients, for TMD or for Bruxism, you should also have in mind there's possibly someone else on the side for you on your patients during the night. The PAD analysis, the watch pad, is a good alternative for sleep laboratory. It's quite cheap and it's easy to handle, but you have to always inform your patients and make sure that they understand everything what you do, because you are entering their sleeping chamber and entering your bed, which is a quite, of course, sensitive field. We always have to work with other physicians and other doctors. This is quite normal. And last but not least, we need more research, and all those persons who do research are invited to think about more about couple sleep. So that at the end, we can improve not only sleep, but also the relationship and their dental health. And with this nice picture from Hanover City with Royal Gardens, this castle which has been rebuilt recently, the castle in which the royal family of the UK had been linked like 200 years ago. So it's a very nice part of Hanover. And if you ever are here over in Germany, just drop in and come to my practice and I'll read you around. So thank you very much for your attention. And I give back now to Steve Carstensen.
Well, thank you, Dr. Hauschild. That I honestly can say, after all these years of practicing and hearing about bed partner reports and being familiar with that study from years ago that you cited about the health improvements of bed partners, this aspect, this way of considering it, this is a new idea for me, and so it's always energizing to hear that. So, where did you come up with this? Kind of this idea to make sure you pay closer attention to the bed partner as, this dyad. That's an interesting concept that, like you pointed out, has some background in literature, but I haven't heard it talked about as a clinical practice.
Well, actually, it was my own history, because I was snoring and my wife had headache. And so I tried to find out whether I could be the reason for it. And the second thing is that I had a lot of patients. I've been doing cranial function for the last 25 years, and I have a lot of mostly female patients who had headache in the morning, who did grinding, who had bruxism. And we found out that all those therapeutic attempts we did were not quite good on the long way. So connecting your examinations with the idea to examine sleep brought us to the idea to regard co-sleep, just to have someone else.
Mm-hmm.
And there are 2 or 3 studies who show that snoring as a sound, as a noise, is something that puts stress in the person. And stress also does something to your facial tissue. It really makes it stronger and harder, which is a very watched through the glasses of evolution, a very sensible thing to make your tissue stronger and harder if someone attacks you. So stress goes into your facial tissue and makes pain. And that's why many patients go to bed without pain and wake up with pain in the neck, in the head, in the jaw muscles. And so we have to reduce stress in the night. And one stressing thing is noise. And it's simple as the same as your alarm clock in the morning. It wakes you up with noise. So if you have this alarm clock lying next to you with 60 to 70 decibels, then you certainly have stress. So if you treat one person, you help the other one, and that's a good message.
Yeah, that's been, I said, I've used that kind of thinking for a while, but you put it together in a way that I didn't expect. And so that was really interesting. Levine talks about microarousals as a source of bruxism. And what you're saying is the snoring could be the source of some of those microarousals. Yeah. So you
Yes, and it's
mentioned,
also harmful for yourself.
yeah.
Snoring is also a condition that put the stress in your own individual body. So it's not that snoring is not considered as a illness, as a pathologic stage. It's just annoying. Yeah, but we think that snoring also is a risk for stress and for apnea, of course.
Yeah, and there's actually good literature about the effect of snoring on the cardiovascular health too, in the carotid arteries and atherosclerosis. Something you mentioned there was that the studies that show that when people use a CPAP, their bed partner's health get better. Do you know if there's any studies like that that include oral appliance therapies?
There are no studies as far as I know, but I have lots of clinical evidence about it because I interview partners, bed partners, and even those patients who come to me without a bed partner because the bed partner doesn't appear or he doesn't want to come or whatsoever, report that the bed partners love it if there's no sound anymore. Interesting thing is that after talking about synchronization, I have not only one, but one patient was a loud snorer, and his wife sent him to me, and he said, "I want to get rid of my snoring," and we helped him with a device. No problem, snoring was away. And about 2, 3 months later, his wife appeared and said, "I need a snoring device too." And I said, "How come?" "Yeah, because my husband now is sleeping so quietly that he's annoyed by my snoring." Yeah. So she needed a device too. She was sent by her husband, indeed. So it would have been better if we would have come together in the first place. But as you can see, people are synchronized, and it works. And actually, this couple has really worked on their sleep alliance. They always used to have separate hotel rooms when they went on holiday, or when they went on a ship. They had 2 cabins, which is quite expensive, and it's not nice. It's not a nice holiday if you just disappear in your single chambers in the night. And so they improved this very much and said we're saving a lot of money because we now only need one hotel room, a single hotel room for 2, with our devices. So this is a lot of nice stories we have around this.
Well, on your intake to your patients, and you have a questionnaire about breathing and sleep and the things that you want to know about what their subjective reasons for seeing you are, do you have a questionnaire for the bed partner, a very specific one for the bed partner, their impacts that the noise or the gasping is causing on their particular quality of life?
Yeah, actually, there is one. This is PSQI, the Pittsburgh Sleep Quality Index. Isn't it surprising that there is a huge part of it concerning the bed partner? So it respects already. There is a hint that we should take a look at the bed partner, but this is we have some other questionnaires as well, but the PSQI is a very common one, and it's in there. It's in there that the bed partner is taken into the whole an amnestic situation. So I wonder why this is not more elucidated.
Well, what I was thinking, yeah, I was familiar with the PSQI because that's for the person who is complaining, has the chief complaint. And they say, well, what do you think the impact is on your bed partner? I was wondering if there's a one that's directed only to the bed partner. So you have a patient coming in to see you because they've driven in for some complaint, and you say, well, take this one home, or as if you have them both in your office, you have the person you're intending to treat, but then also you had a separate focused questionnaire strictly for the other person. Do you know of
Yeah.
anything like that?
Yes, of course. I do special appointments for couples.
Hmm.
And this is communicated just before they come into my practice. So they indeed get two questionnaires,
Really?
each for everyone. And it is very, very interesting to see how sometimes differently they judge their own sleep. And what we saw in this one study with those four couples in the PSG that they are synchronized, and that what we can see at the study of Monroe in 1969, that female bed partners subjectively judge the sleep differently from the objective results that we have from the study. So in other words, they get annoyed and disturbed by the sleep, but they want to have it. They want to have this couple sleep because they feel more secure and want to be with their bed partner. And this expresses itself in those questionnaires. It's very interesting. Just give one questionnaire to the one bed partner and the other one to the other one, and you get sometimes more information by the combination of those two scores.
Very good. Yeah. Um, tell us, I mean, it's lovely to hear about the results you and your wife have had using your Panthera devices. Tell us another story about a couple that has an unexpected outcome because, they weren't maybe even considering having both of them in the room, but then you got them through your process. Tell us a story about that.
Yeah, well, there are lots of stories. The nicest thing is always about traveling with those patients. We had one a patient who was a sailor. He loved to be on his boat and sail, and of course he did it with his wife. But his wife sort of skipped out and didn't want to do it, and so he was quite unhappy because he loved to spend his time on his boat. And his wife said, "I'm not going to come with you. It's not. I don't like it that much." And that was, of course, really a problem for those two. And we found out that the problem was not that she didn't want to sail or didn't want to be in the boat or in the sea. It was just the problem that they could sleep because they were so stuck together in those sleeping cager. So and he was snoring so loud so that the nights were completely not restful at all for the
Mhm.
for the wife. So she was suffering. She was suffering on board. She was tired the next day, and she needed a holiday right after this sailing holiday. And giving the man, who was an apnea patient, and indeed was wearing a mask. He was wearing a CPAP, and he didn't know that there were oral devices that he could use. He just didn't know it. No one told him. But the problem was, he figured out by himself, I have no electricity on board. And what do I do without a CPAP? So I have to find something else. And I said, okay, try it with a mandibular advancement device, which we gave him. And he said, well, it's working even quite better than the CPAP. And it's very, very quietful now. And that brought his wife back on board.
I don't think there's near enough emphasis placed on quality of life benefits as there is on medical benefits, especially our physician colleagues. They spend a lot of time considering the impact of these sleep disturbances on long-term cardiovascular health and other extremely important things to be thoughtful of. But I believe that if we bring up the emphasis on quality of life impacts of these things, like you've been doing for this whole webinar, I believe that's going to be a powerful way of getting more people interested in getting their airway treated.
Definitely. And you always have to bear in mind, I've read it on your platform, that Steve Lamberg who is a dentist, yeah? And he's written this book about 170 diseases who are linked to sleep apnea. And I think we dentists have a huge advantage because we see all those patients. You see, in Germany, it's very popular that people go to the dentist 1 or twice a year. So we look into the oral cavity. We can see all those signs, all those symptoms of sleep apnea, and we can ask simple questions. How is your night? Do you snore? Do you have a bed partner? Who? And so on. So we have an enormous, tremendous filter capability to find out about persons who are having an apnea and not even knowing it. And at the end of the day, we can send those patients to a physician and get to a sleep laboratory whatsoever. And at the end of the day, we can help them with our mandible advancement devices. So we have an enormous, tremendous weight in dentistry. Just even if we would not only understand it, but if we sort of get it into the society, because in Germany it's not so well known as it should be. We have 20% of people having sleep apnea. And we have only 130 dentists here in Germany who are certified for dental sleep medicine. This is quite a long way we have to go still.
Yeah, it's not any better here in the United States. We have 350 million people, tens and tens of millions of people, and still so few diagnosed and much less treated. So, the and Steve Lamberg, I'm happy to say, is on our board of our editorial board of Dental Sleep Practice Magazine and a frequent contributor and a very good friend. So I'm glad you're enjoying the book that he wrote. Being translated, I think, into German, actually.
Oh yes, it is, and I'm really advertising it. Yeah.
Oh, good for you. Good for Steve. It's good for all of us when we spread the word like that. And I do want to point out that you mentioned that somebody who's diagnosed in your clinic that has sleep apnea and somebody else who's diagnosed without sleep apnea but still has bruxism because of whatever reasons they have bruxism, they can get the mandibular advancement device. And you're being a very good doctor for individual precision care. And that I think is excellent. And Panthera has a wonderful night guard, protective guard to go along with their high quality other devices. And so we can still have matching devices for couples.
Yeah, definitely. And see if the improvement of those devices, which we definitely had, makes it easier to wear. Because people don't want to wear it into their mouth. They have thick tongues and they have no space for it, and they really refuse sometimes to have something in their mouth. So we have good developments. We have digital devices, just like as scanners, where we can do sort of casting. We have CAD/CAM. We have what I do now is digital recording of the temporomandibular joint, so we can really produce very precise devices. And if they are more precise than it was in the earlier years, people accept it better. And you have a better adherence to the therapy than before.
Back to our main subject here for a moment. Do you ever suggest that the bed partners sleep separately? I mean, I saw that your testing is done, with the watch pads both at the same time, same room. Do you ever say that they should sleep solo for like a test night or anything? Is that ever a recommendation from you?
Well, talking with or saying in the words of Wendy Truxell, there's no one size fits all therapy, and of course for some couples it's better to sleep in separate rooms. There's this chronobiological point that you have to really respect. If you have a lark, if you have an owl, they have to match somehow, and it could be really different from this point of view. So you always have to look at it very individually. But as far as I have experienced it, most couples, no matter what chronobiological background they have, want to sleep together. They really want it because they know it's good for us, it's good for a relationship. And if we have this sleep divorce, this might be possibly the beginning of the end. So I feel there's a quite sort of a bit of a pressure not to have separate sleep rooms. So I recommend it, of course, because I try it. I work on it because I know how refreshing, how good it is to have someone on your side in the night, and this gives a new quality of life, definitely.
Well, I really appreciate all the questions that people have sent in, but we're out of time today. If we didn't get to your question, I apologize for that. And I hope you got a lot out of this fascinating talk. And Dr. Hauschild, I really enjoyed hearing what you had to say and giving me a whole new perspective on what we can take back to our clinic. And so I thank you for your contributions. I really very much thank Panthera Dental for supporting this webinar. And I hope you guys all have a great evening.
Thank you very much.